right, very good. So let's see. So our next presenter is going to be virtual as well, but we'll be bringing her in for Q&A after. This is Dr. Khan. She's a clinical professor of medicine, divisions of endocrinology and metabolism, and geriatrics at McMaster's University. She is the director of calcium disorders clinic as well as fellowship in metabolic bone disease at McMaster University. So let's pay attention to Dr. Khan.
Thank you so much for asking me to speak about advances in drug therapy. And I will be presenting what's new in the treatment of hypoparathyroidism. And it really is my pleasure to speak to everybody today at the Hypoparathyroidism Conference. These are my disclosures. And I wanted to begin by reminding everybody that normally the serum calcium in our blood is very carefully sensed and regulated because calcium is essential for every single cell in our body. And so when the serum calcium goes down, when the blood calcium goes down, the calcium sensing receptors on the surface of the chief cells in the parathyroid glands, and these receptors are in other tissues as well, most notably also in the kidney. And this reduction in serum calcium is sensed by the receptor on the parathyroid gland cells, and it increases the synthesis and the secretion or the release of parathyroid hormone. And the calcium sensing receptor works like a thermostat. So in our house, we have a thermostat, and when the temperature in the house goes down, the thermostat triggers the furnace to go on to generate heat. So in the same way, when the blood calcium goes down, it's sensed by the receptors on the surface of the chief cells, and they increase parathyroid hormone production. And what parathyroid hormone does is it will bring that calcium back up, just like the furnace will elevate the temperature in the house because the house was too cold. So how does parathyroid hormone bring that calcium back up? The immediate next step is increase calcium reabsorption through the kidney. And every day we filter 10 grams of calcium through our kidney. So if someone is taking 1 gram of calcium, well, we filter 10 times that amount. It's a lot of calcium in a 24-hour period that is filtered through the kidney, and then we reabsorb 9.8 grams. And we need parathyroid hormone to do that. So if we don't have parathyroid hormone, then we have a major leak of calcium through the kidney. And why is that a problem? Well, that is a problem for the kidney. It can cause kidney damage. It can cause calcium deposits through the tissue of the kidney. It can also cause kidney stones. So it's very bad for the kidney to be filtering all this calcium and not reabsorbing that calcium. So high urine calcium is detrimental for kidney function, and it contributes to kidney stones and calcification of the kidney. And also, it's a loss of calcium. And so this is one of the reasons why that calcium is contributing to the low serum calcium. So parathyroid hormone brings that calcium. It increases the absorption of calcium, and that will help to bring that calcium back up. The next thing that happens with parathyroid hormone, so this happens within minutes. The next effect of parathyroid hormone over hours is increases in bone resorption. So our skeleton is a reservoir or a bank for a number of minerals, calcium and phosphate and magnesium. They're stored in our skeleton. And parathyroid hormone will cause osteoblasts to release a signaling protein, which causes the osteoclast to dig out more bone and release calcium and phosphate into the bloodstream. And then if that serum calcium is still low and parathyroid hormone is still elevated, the third effect of the high PTH is to increase the activation of vitamin D. So vitamin D will become activated in the kidney to become 125 dihydroxyvitamin D, which is calcitriol. And so these three effects bring that calcium back up into the normal reference range. So if someone does not have parathyroid hormone because the parathyroid glands were removed, and 75% of people who don't have parathyroid hormone, enough of it, will have this post-surgical because of damage to the parathyroid tissue. Or it could be because of other reasons. And the most common cause is autoimmune. And this could be an isolation or as part of a syndrome, autoimmune polyendocrine syndrome 1, where we can also have fungal infections in the mouth. And they can also be adrenal gland damage as well as other tissues can be damaged. So there are many other symptoms and signs of autoimmune polyendocrine syndrome and other conditions associated with it. So there could be many reasons why the parathyroid glands aren't functioning, but the effect of inadequate parathyroid hormone is a low serum calcium. And because we don't have parathyroid hormone, we don't have the ability to correct this low serum calcium. And we're losing calcium through the kidney. We're not able to get the calcium out of the bones. So it's staying in the skeleton, and we're not able to activate vitamin D. And activating vitamin D helps us to more efficiently absorb calcium and phosphate in the bowel. And active vitamin D also helps us to get the calcium out of the skeleton. And so people who do not have adequate parathyroid hormone have these features. So we recently had a major consensus conference, and we did review the entire global literature, and we developed new guidelines for the evaluation and the management of hypoparathyroidism. And there were 8 papers that were published looking specifically at hypoparathyroidism. And this is the summary statement. And all of these papers were just published in December of 2022 in the JBMR. And these papers are now available online for everyone to review. And we confirmed that we make the diagnosis of hypoparathyroidism in the presence of a low serum calcium and a low or an inappropriately normal parathyroid hormone. Because if calcium is low, and if the parathyroid glands were functioning normally, then parathyroid hormone should be elevated. It should be elevated. So if it's not elevated and it's just sitting in the low normal reference range or the middle normal reference range, then that's inappropriate. It's just like if the house is cold, the furnace should be working excessively, not just coming on and off every now and then. If the house is cold, it should be working continuously to elevate that temperature. So in the same way, parathyroid hormone should be elevated. So if it's inappropriately normal or low, then that confirms that we have inadequate parathyroid function. And we had a large group of co-authors. This was a huge global effort. And we had approximately 100 experts from around the world helping us to develop these guidelines. And Michael Manstad was leading one of the teams that was looking at the diagnosis of hypoparathyroidism. And in this paper, we confirmed that a low serum calcium confirmed on 2 separate occasions, at least 2 weeks apart, in the presence of a low or inappropriately normal PTH, confirms the diagnosis. Another important point to remember is that parathyroid hormone will increase calcium reabsorption, but it eliminates phosphate. So if we don't have enough parathyroid hormone, phosphate levels start to climb. Why is this a problem? Because calcium binds with phosphate and it can calcify tissues that should not calcify, such as elements in the brain, such as blood vessels in the heart, cardiovascular calcification, such as kidney tissue, such as the lens in the eye. And we can get cataracts, we can get heart disease, we can get kidney damage. And so it's very important that we keep that phosphate in the normal reference range. We should not allow it to be high because this will contribute to calcium deposits in the brain, the basal ganglia, and deposits of calcium in tissues that are not supposed to calcify. And we also know that if we are not able to activate vitamin D, our ability to absorb calcium from the bowel will be impaired. And this will also contribute to low serum calcium. And active vitamin D helps us to access the calcium in our skeleton. And as I mentioned, there are many reasons for developing inadequate parathyroid hormone function. 75% are post-surgical, but 25% are autoimmune. And then we have genetic variants. So the genes that are necessary to form normal parathyroid tissue have a mutation in them. And there are many genes that are required to form normal parathyroid tissue, and the function of the parathyroid glands is also determined by genes, various genes, and the effects of the parathyroid hormone on the end organs is also going to be affected by various genes. So there could be genetic variants that will have an impact on the synthesis and secretion and the effects of parathyroid hormone. And these glands can, in some people, be infiltrated with granulomas. And it's important for your doctor to evaluate granulomatous disease because this could be the cause, such as sarcoidosis or amyloidosis. This can be a cause for an abnormal parathyroid function. And the glands can also be damaged because of deposition of copper or iron or aluminum. Some patients who have cancer that has spread to other tissues can develop inadequate parathyroid gland function. And the cancers that can do that include skin cancer, breast cancer, leukemias, lymphomas can do that. Radiation, the glands could be radiated and therefore not be functional. If magnesium levels are high magnesium can turn off parathyroid function. And we also need magnesium for the actions of parathyroid hormone. So there can be a tissue resistance to parathyroid hormone if magnesium levels are not normal. So it's important for physicians to evaluate magnesium whenever calcium is evaluated. In the presence of burns or severe acute illness, we can also see that the parathyroid function can be affected. And pregnant women who have an overactive parathyroid gland can have babies born with underdeveloped parathyroid tissue. So there are many reasons for inadequate parathyroid function, and doctors need to evaluate this, determine is it post-surgical or is it non-surgical. These are all the non-surgical causes, and then find out why our patient has hypoparathyroidism. And we also recommend that we look at other features to see if there are other diseases that need to be evaluated in determining the underlying cause of the hypoparathyroidism. Now, what are the complications of hypoparathyroidism? And looking at all the global literature, what we found was that these are the common complications of hypoparathyroidism. And 24% of people with hypoparathyroidism can have cataracts. People with hypoparathyroidism can have infections because the immune cells need calcium to function. They can get kidney stones and calcification of the kidney tissue. Kidney damage can happen. Kidney function can be impaired. They can develop seizures because the brain cells need calcium. They can be depression. They can develop heart disease because there could be calcification in the blood vessels. And there can be arrhythmias because the QT interval, the electrical circuitry of the heart can be affected when calcium levels are low. And so these are how the manifestations of hypoparathyroidism present today. So how do we treat hypoparathyroidism? Well, we can give back calcium. And usually we have to give large amounts of calcium, and we can give 500 milligrams 3 times a day. We always give calcium with food. The reason why we give calcium with food is because then it does two things. First of all, we're giving the calcium with the meal, and then it will also bind the phosphate in that food. And so it will bind the phosphate and get rid of it through the stool. So all my patients, I tell them, be sure you always take your calcium with your food. Take it with breakfast, take it with lunch, take it with dinner. And we start with 500 milligrams 3 times a day. If that's not enough, then we can go up higher and higher. Some patients need 3 to 4 grams 3 times a day or even 4 times a day. Large doses of calcium may be required. We always emphasize taking the calcium with food so that it will bind the phosphate and help to bring that phosphate down, because phosphate, when it's high, it causes ectopic calcification or calcification of tissues which are not supposed to calcify. Patients can take calcium carbonate or calcium citrate. Either of those are good options. We also want to correct vitamin D. Vitamin D should be normal. And we give active vitamin D because parathyroid hormone is a value in forming active vitamin D. So it enhances the activation of the vitamin D, and patients with hypoparathyroidism will need active vitamin D. Now, some patients have mild hypoparathyroidism. They still have some parathyroid functioning tissue, and they just need some calcium supplements 3 times a day. But if there is hypoparathyroidism, patients might just need 0.25 micrograms once a day. I have some patients who just take it 3 times a week. But then we have other patients who need higher doses of calcitriol. Now, the half-life of calcitriol is 5 to 8 hours. And so it's ideally given twice a day, or sometimes it can be even given 3 times a day. So you can begin by 0.25 micrograms once a day. And if we need to go up higher, we can go up to 0.25 micrograms twice a day, because it doesn't last the 24 hours. So it's best to give it in divided doses. Alpha calcidol is available in Canada, but it's not as powerful as calcitriol. It's only half as powerful as calcitriol, and it can also be given in doses that are built up. And we also can give thiazide diuretics, and what these drugs do is they increase calcium reabsorption through the kidney. But they can be a problem because they can cause magnesium to be lost and potassium. And patients who have autosomal dominant hypocalcemia already have a problem with magnesium. So we do need to be careful about thiazide diuretics. They can also, in young people, cause the blood pressure to go down and cause dizziness and lightheadedness. Now, we looked at all the world literature and looked to see how effective parathyroid hormone was in comparison to conventional therapy, calcium and active vitamin D. And we found that the net para drug, PTH 1 to 84, in comparison to calcium and active vitamin D, was a value in increasing serum calcium, so allowing the amounts of calcium and active vitamin D that were being taken by patients to be reduced significantly. And it was helpful in keeping serum calcium in the normal range. And what was seen was that the calcium phosphate product, combination of those two, and the serum phosphorus did go down. So that was a good thing. But urine calcium went down in both the PTH group and the active therapy group. So the reason why we feel that it was not as effective in normalizing urine calcium could be that this molecule has a half-life of 3 hours. So it doesn't give us 24-hour protection for the kidney. And there are other studies as well that have been done showing that there was no reduction in urine calcium with this molecule. And we feel that this is a reflection of the fact that this drug does not have 24-hour coverage. There is teriparatide, PTH 1 to 34, and this has been evaluated in a number of trials by Karen Weiner and her colleagues. And these studies have shown that we can maintain normal serum calcium, but when we give the parathyroid hormone in multiple doses or as an infusion, then we're more able to reduce urine calcium. And so it confirms again that just giving a single dose of PTH is not enough, because PTH 1 to 34, its half-life is 1 hour. And so again, it doesn't give us that 24-hour coverage. It has to be given at least twice a day for us to see an impact on urine calcium and to provide an impact on patients' well-being and reduce the complications that we're seeing. There was a phase 2 study looking at TransCon PTH. And what TransCon PTH is, teriparatide, it's PTH 1 to 34, but it's connected to a polyethylene glycol molecule that protects this and increases the half-life of this drug from 1 hour to 60 hours. So it gives us that full 24-hour coverage. And what we've seen with this drug is that it will maintain serum calcium and it will reduce the urine calcium losses. And we've seen that in the phase 2 and the phase 3 studies. And we've seen a dramatic improvement in patients' well-being and reductions in the need for calcium and active vitamin D and reductions in urine calcium. And so this is what it looks like. We've got the PTH 1 to 34, and it's connected to this molecule. And when we give it, when we inject it, and it's injected subcutaneously into the abdomen, or it can be given in the thigh, then what happens is that the linker is cleaved and the drug is cleared through the kidney, and the PTH will have an effect on the PTH receptors, but its effect is over 60 hours. So the effect is over 60 hours, and it provides stable levels of PTH over the 24 hours that we need for our patients. And this TransCon PTH in the phase 3 study was evaluated 18 micrograms in comparison to placebo at week 26, looking at how many people were able to keep the serum calcium in the normal range and stop their calcium supplements and be able to stop active vitamin D. And stopping calcium supplements meant that they were taking less than or equal to 600 milligrams of calcium just as a nutritional supplement. And these patients were very closely followed. And what was seen was that 79% of patients were able to meet all of those criteria. And you can see that 98%, so basically all of them except for one person, was able to stop completely active vitamin D. And 93% of patients were able to reduce their calcium supplements so that it was less than 600 milligrams a day. So that's really very impressive. And if we look at their serum calcium, it was in the normal range off calcium supplements, and all of them except for one person was off active vitamin D as well. And this is the placebo group. And we can see that calcium doses were like less than 500 milligrams, and everybody was able to stop active vitamin D except for one patient. So that was really impressive. And what we saw was a dramatic improvement in patients' well-being. And my patients who have been on this medication, they've been able to come off disability, they've been able to go back to work. Young students have noted a dramatic improvement in their scores at university. They've been able to get jobs. Some of my patients have begun to travel. They're climbing mountains. They're building houses. Their life has changed. And many patients have told me it was like going from a dark room and coming out into the open air. So this is the benefit of giving back the missing hormone, not just for a few hours of the day, but covering 24 hours of the day, every day. Make sure that we have that parathyroid hormone impacting on the brain, making sure that parathyroid hormone is going to normalize serum calcium, drop that phosphate, drop that urine calcium. And very recently, we've seen that TransCon PTH can actually reverse, it seems to reverse the kidney damage that we've seen in patients. And this is a very promising treatment, resulting in major benefits in patients that we've already seen. And we're expecting with our long-term data, even further impact on reducing these complications of hypoparathyroidism that we were talking about. Now, in the new global guidelines, we said that patients should begin with conventional therapy, which is calcium and active vitamin D. And if it isn't enough, if serum calcium is not properly controlled, calcium levels are going up and down, or patients don't have enough impact on the brain fog and the ability to think clearly and function like they were before, or if phosphate levels are high, or the urine calcium is high, then we do recommend going on to PTH therapy. And we recognize that we need longer and larger studies to evaluate this further. But we do recommend normalizing the phosphate levels and dropping that urine calcium into the normal reference range and improving the symptoms and bringing that serum calcium just below the normal reference range or in the lower half of the normal reference range. And we recommend normalizing magnesium and vitamin D. In pregnant women, we recognize that a woman is pregnant if they have hypoparathyroidism. We know that the breast and the placenta also secrete PTHRP, which is like parathyroid hormone. And this can help to get calcium out of the skeleton. And this can help to form active vitamin D. And it acts like PTH. And pregnant women, we need to monitor their serum calcium very closely. And we need to ensure that calcium is in the normal reference range. And this is essential for the fetal parathyroid glands to develop normally and to ensure that the pregnancy outcomes for both the mother and the baby are ideal. Now, I wanted to say a little bit about new therapies as well for this presentation. And some patients have autosomal dominant hypocalcemia type 1. And this condition is caused by a mutation in the gene that encodes the calcium sensing receptor. And it's a gain of function mutation, which makes this receptor super sensitive. So what is happening is the receptor is thinking that the calcium levels are higher than they really are, and it's turning off PTH. So it's like our thermostat thinks that the temperature in the house is higher than it is, and it keeps the furnace off. So that's a problem. And there's nothing wrong with the furnace, but the problem is with the thermostat. So if we could give a drug that can normalize the function of the calcium sensing receptor, then the parathyroid gland can function normally. And this drug that is being evaluated is called encaleret, and it can normalize the sensitivity of the calcium sensing receptor. And it can normalize parathyroid hormone, and serum calcium. And it can normalize urine calcium in people with autosomal dominant hypocalcemia. There's another drug that is being evaluated, and this is called eneboparatide, and it's a long-acting PTH-PTHRP analog. And what it does is it binds to the PTH receptor, and it stays bound to the PTH receptor even after it's been cleared through the bloodstream. So it stays bound to the PTH receptor, and it allows the PTH receptor to continue to have an effect. And this allows the drug to have a long-acting effect on the PTH receptor. And this has been shown in patients with hypoparathyroidism to reduce the requirements of active vitamin D and calcium. And it also has been shown to decrease urine calcium. And this drug is also undergoing clinical evaluation and phase 3 studies. So I'd like to conclude by saying that hypoparathyroidism is a condition which is a serious condition, and it is associated with long-term complications, which without parathyroid hormone therapy requires high doses of medications given in multiple doses throughout the day. And this is not an easy condition to treat. And patients are severely affected by this. It can affect the clarity of thinking. It can affect vision by causing cataracts. It can cause seizures. It can cause anxiety. It can cause depression. It can have an effect on lung function. It can cause bronchospasm. It can cause heart failure. It can cause cardiac arrhythmias. It can cause kidney damage, kidney stones. So it has a major, major effect on an individual's quality of life and their function. And by giving back the missing hormone, we can correct this problem. And research is advancing very quickly in hypoparathyroidism, and we anticipate that our ability to treat patients with hypoparathyroidism is going to dramatically improve when teriparatide becomes available, which is expected to happen in Europe very soon, and also in the US very soon, and hopefully in Canada next year. And we also have other molecules that are being evaluated as well. And so the treatment for hypoparathyroidism is really going to be revolutionized. And I've seen this in my patients who are on teriparatide, a dramatic improvement in their quality of life and their ability to function on a regular basis, on a day-to-day basis. I tell my patients, if I had this condition, I wouldn't be able to do my job as I'm working today. If I didn't have access to PTH. I don't think I could be taking all those doses of calcium and active vitamin D and still be working at the rate that I'm working if I didn't have access to PTH replacement therapy. So with that, I'd like to thank you for your attention, and I would be happy to answer any questions as I will be taking them live. Thank you so much.
All right. Dr. Khan, always a pleasure. Hello. We're happy to see you. All right. So we're going to have some questions. Thank you so much. Your presentation was absolutely wonderful. So questions from the audience first, and then we'll go online.
A few years ago, I saw a doctor at Chicago University, Tamara Vokes. She's retired now. She did a lot of the clinical trials for NatPara. She told me to get as close to 7.5 in my calcium. I only have one kidney and stage 3 chronic kidney disease. And everything I've heard today says 8.0 for like the lowest spot. So should I be trying to run it closer to 8 or keeping it in the mid 7s?
So that's a really good question, and we do aim for the calcium to be at the lower level of the normal range or just below it, because we don't want to run patients too low, because that can affect your ability to think clearly. It can increase your risk of complications. So that's the goal. And it's important, that is our target, we want to also keep phosphate normal and the urine calcium normal. The more calcium and active vitamin D we give, the higher the urine calcium will be. So if we can keep your calcium a little bit closer to the normal range while maintaining a normal serum calcium, then that would be ideal, and a normal phosphate.
And I
So
just
it,
had one other quick thing. Did I hear you say that TransCon can reverse kidney damage?
yeah, it seems
Wow.
that way.
That's all. Thank you.
Yeah.
All right, anybody else from the audience, and then we'll go online? Michelle?
Okay. If one is on a potassium-sparing drug for hyperaldosteronism and has to watch their potassium in their diet, is thiazide recommended?
Well, if they might not need it. So I would recommend that such individuals simply continue with the calcium and active vitamin D. We can certainly combine spironolactone with hydrochlorothiazide as well, but using higher doses of diuretics can cause blood pressure problems, as we discussed. So if the blood pressure goes down, it can be a bit of an issue. So if you're already on a potassium sparing diuretic, then it may be adequate to just go ahead with the calcium and the active vitamin D instead of adding hydrochlorothiazide.
Okay.
And the next question from online is, what is a clinical sign that you should increase your calcitriol instead of your calcium?
So basically, it depends on a number of factors. If the phosphate levels are high, we prefer to increase the calcium and always give it with food, because calcium binds to the phosphate and gets rid of the phosphate. If the phosphate levels are high and we increase the calcitriol, that'll make the phosphate levels even more high. So it's better that we're careful with what we're trying to achieve. So if the calcium levels are low and we want to normalize the calcium, we look at the phosphate and the urine calcium. And if the calcium is low and the phosphate is high, I prefer to give more calcium. If the calcium is low and the phosphate is normal, then I would give more active vitamin D. But I also look at the urine calcium, and I also look at the doses that the patient is on right now.
Go ahead.
Okay. What is the effect of TransCon on the bones?
Okay, so what we know that patients with hypoparathyroidism, we have done bone biopsies on these individuals, and we've seen that there is more dense bone structure. And this is an area that is being investigated further. We don't have any prospective data looking at the risk of fracture in patients with hypoparathyroidism. What we've seen so far with TransCon PTH is that patients who start TransCon PTH start with a higher bone density, and that bone density comes down towards the normal reference range. And we are seeing that there's an increase in the rate of bone removal and bone formation. And then this comes down and is established at a level that is closer to the normal reference range. But we will be looking at long-term skeletal data, and we will be evaluating this further.
Okay.
If we don't have a parathyroid anymore, why do we need calcium supplementation in addition to the calcitriol?
So we do need calcium, because just giving calcitriol, what calcitriol will do is it will increase the absorption of calcium and phosphate from the bowel, and calcitriol increases the formation of osteoclasts. And so the osteoclasts can get calcium out of our skeleton and shift it into the bloodstream. But we also need to make sure that our patients are getting calcium, because we need the calcium from food sources. Otherwise, we're only getting calcium out of our bones. So if patients don't have PTH, then they're not able to form their own active vitamin D, and they need active vitamin D to increase the absorption of calcium and phosphate from the bowel. So they need to be taking calcium, and we also supplement it with calcitriol because they don't have enough of their own endogenous calcitriol. So we like to give both. Just giving calcitriol will not be adequate because we'll just be accessing the calcium from the skeleton, and we want to be able to ensure that patients are taking calcium as well.
Okay.
Thank you. Is there a standard dose of magnesium you recommend?
Well, the magnesium has to be measured. And we know that if we have very high levels of magnesium, it can bind to the calcium sensing receptor and turn off PTH. And we know that if the magnesium levels are low, it's a cofactor to adenylate cyclase, which affects the function of PTH. So magnesium has to be normal. And we measure magnesium, and then we adjust the supplement based on the level. So for example, patients who have autosomal dominant hypocalcemia, they can have a leak of magnesium through the kidney. And these patients need high doses of magnesium. And in these people, giving them hydrochlorothiazide can make that magnesium leak even worse. So we have to be very careful with magnesium levels in these individuals. But we have to measure magnesium and adjust the dose accordingly.
Okay, thank you. Someone is asking if PTH is, wait a minute, let me go back, I'm sorry. PTH is not enough to absorb calcium from the gut. How come calcifications might occur from the calcium supplements?
Right. So coming back to that initial diagram, which I showed, so what PTH does is it helps us to reabsorb calcium from the kidney, right? Because every day we filter 10 grams of calcium. That's 10 grams of 1,000. So that's a lot of calcium. That's 10,000 milligrams of calcium. So we filter 10 grams, and then we reabsorb 9.8 grams, or 9,800 milligrams of calcium is reabsorbed every day. And that is dependent on PTH, amongst other hormones. And the other thing that PTH does is it increases the formation of active vitamin D. And so this active vitamin D helps us to absorb the calcium from the bowel with the phosphate. And then PTH also helps us to get the calcium out of our bones. So those are the three effects of PTH. And by those three effects, PTH is able to bring that calcium back up into the normal reference range. So if someone doesn't have PTH, just giving them active vitamin D isn't enough. We also want to be able to give them calcium, and we want to ensure that they're absorbing that calcium. So we do give them active vitamin D. And because they're not able to access the calcium from their bones, and they're not able to reabsorb the calcium from their kidney, there's going to be this loss of calcium through the kidney, and the calcium in the skeleton is not being accessed. So that is the problem that we have. That's the dilemma. So we want to be able to ideally give back PTH. And once we've got a molecule that is going to provide 24-hour coverage, then that's what we want our patients to be on.
Okay. The next question asks, if we don't have enough PTH and calcium is not absorbed through the gut, how come it ends up in the kidneys instead of the bowels?
Right. So why do we get the ectopic? Why is the calcium deposits in other tissues, right? So what happens is that the calcium binds with phosphate and it deposits in other tissues if this calcium phosphate product is high. So if phosphate levels are high, it will bind to the circulating calcium and it deposits in the brain. This is why it's very important to keep that phosphate normal. It's absolutely critical that the calcium phosphate product not be high. We don't want phosphate to be high because phosphate will bind with calcium, and there'll always be calcium in the bloodstream because we need calcium in the bloodstream. So if the phosphate is high, the phosphate will bind with the calcium, deposit in the lens of the eye, deposit in the brain, deposit in the kidney, the parenchyma of the kidney tissue, and cause damage to the kidney. And high urine calcium will contribute to kidney stones. And high urine calcium also declines renal function. It's detrimental to renal function. This is why we have to drop that phosphate. We have to drop that urine calcium loss because high urine calcium will contribute to further decreases in kidney function, and it will contribute to kidney calcification. And we don't want that. We want to preserve kidney function. We don't want the patient's kidneys to calcify, and we don't want patients to have kidney stones.
Okay, we have 2 audience questions.
Hello, I have a question. My phosphate is a little high, 5.3, but my endocrinologist is not worried because it's just a little over the 4.5. So at what point do we need to be worried about these too much phosphate forming these deposits in tissues we don't want them to be in?
Oh, we don't want the phosphate to be higher than normal.
So 5.3 is something that you would already be treating?
Yeah.
Okay, thank you.
Yeah. And if you ask your endocrinologist to review the new guidelines, we clearly said that phosphate has to be normal.
Hi, doctor. This is John. We saw you in Buffalo a few years ago and left a great impression then, and you're even better now, kid.
You're too kind.
I hear you on the phosphate. I've got high calcium phosphate. What's the best way to address it? How do I get it down?
Well, it depends on how well controlled the serum calcium is. And if we can drop the calcitriol dose, then that would be good. And so I would increase the calcium, start dropping that calcitriol, because the goal is to drop that phosphate. And we always give calcium with food, so it will bind to the phosphate in the food. Also, going on a low phosphate diet can be helpful. And if there is still a high phosphate, then sometimes we add in other phosphate binders like sevelamer. But there's lots of strategies to lower phosphate. And it's based on the diet, go on a low phosphate diet, make sure that the calcium is always taken with food because it binds to the phosphate and gets rid of it in the stool. Try and reduce the calcitriol dose. And think about PTH. You know, you might want to try PTH, teriparatide, even just once a day can be helpful because it will help to reduce your calcitriol dose. And if we reduce the calcitriol dose, the calcitriol is what's causing the phosphate to go up. So the calcitriol is a double-edged sword. You know, it helps you because it helps to increase the calcium, but it hurts you because it increases the phosphate.
Okay. All right. Well, Dr. Khan, thank you so much for all your time and attention to the hypopara community. We just appreciate all the work that you do. Let's give it up for Dr. Khan. Thank you. All righty. So there we are. We're at the end of our very informative day today. I hope you guys have enjoyed it. Have you enjoyed it? Yes. All right. Very good. So we still, tonight, we're going to have our buffet dinner will start at 5:45. We're also going to have a keynote speaker in here. We really we know how hard it is to live with a rare disease, so we wanted to make sure that we touched on that emotional, mental part that happens with a rare disease. So she's going to be talking to us about how do we live with a rare disease. So when you go for your buffet dinner at 5:45 in the lobby, you can bring it back in here, and she'll get started at 6:20. We'll have her for about 45 minutes, and then we actually have s'mores by the fire pit later on. If you want to join us, we'll be outside. Bring your coats, of course. We got some really long skewers to do some s'mores tonight, so that'll be fun as well. And I think that's probably it for today. Thank you guys so much for everything. Thank you for being here, and we'll see you in a little bit.